Well, welcome. I'm really excited to have you back in our Facebook group.
Thank you. Yep, happy to be here. We had such a great response and questions and feedback from the last time we did this, so I'm happy we're going to be able to do this more often.
Yes, I am too. I think our combined efforts are really there to make a difference, and I am excited to share. Okay, I'm just doing a check here. I can see us live. That's excellent. It's always a good thing when this works.
We did it, right? All right, we're on.
So we've actually been collecting questions throughout this week, and we have a set of questions that have come in, some that are much more appropriate for Dr. Lucas to answer, and some that are on the exercise front that are appropriate for me to answer. And there are so many questions that I'm thinking we will just dive in and start, because otherwise we could be here for a very long time.
Yeah, let's dig in.
Let's do it. I'm going to go ahead and share my screen and bring up those questions, and then we can all see the same thing. Oh, you wouldn't do that? Okay. Okay. Honey's going to bring them up on a separate screen. Okay. So
I've got them up here too. If you want me to start at the top and work our way down.
Let's do that.
Okay,
Let's start at the top and we'll work our way down.
Yeah, so the document that I'm reading off of, Sarah has so nicely prepared and has some very updated stuff. So these are people, I think, from just recently that put some of these questions in. And there are some big themes. So if I answer one very specifically and it's the same as another, I'll probably just mention that and skip over it. But so this first one is really something it's difficult to answer, but the person who's asking it, I don't know if I should say names or not, but the person asking it is asking specifically about a drug called Aclasta, which is, I believe that is a European form of Reclast, I'm pretty sure, which is a bisphosphonate, an IV bisphosphonate. And she says that she's terrified, and should she be? And unfortunately, I see this all the time because there's so much, there's a lot of information, some misinformation, a lot of misunderstanding around the drugs. And to be open and honest, I'm not anti-drug, but I'm not really pro-drug either. And so I think that there is a time and a place for the drugs. And so unfortunately for the person asking this question, I can't tell you if you should be terrified because I don't know what position you're in. I don't know how quickly you're losing bone. I don't know, what your starting point is. I'll just tell you my summary around bisphosphonates is that they are a class that is grossly overutilized. They're one of the most common drugs prescribed for osteoporosis, and so it's going to be like, Fosamax, Reclast, Actonal, all of the oral and IV bisphosphonates. And they work by slowing down bone loss. So they actually poison the cells that break down bone, osteoclasts. And in doing so, they can improve bone mineral density. The challenge I have with these drugs is manyfold, but the main one is that they also slow down bone building. So over a long enough period of time, you will see an increase in bone mineral density, but you're not really building good bone. So what we've found with these drugs is that the longer you're on them, the more likely you are to see some of the serious side effects, which includes this thing called osteonecrosis of the jaw, which is terrifying, and then atypical femur fractures. And the reason for that is because you've squashed bone metabolism. And so there is a time and a place for these drugs, but without knowing why you're losing bone, how quickly you're losing bone, I think that going on these drugs out of that context is not the first choice that I would certainly choose. And I think something that if that is the case, then I would pursue more information. Are you rapidly losing bone? Is this your only choice? And then also ask your doctor, what's the long-term plan here? Because you can't take these drugs for more than 3 to 5 years. So what's next? And that's going to vary depending on your circumstance.
I think that's a great answer to that one. And I had a follow-up question myself with that one. If someone is taking bisphosphonates, is there are there things that they can be doing at the same time that are also going to help to improve bone quality?
Sure. Yeah, we see this a lot. And I actually think there's one of the next questions down here is in the same category, which is somebody who's talking about having, she said that she had a triple negative stage 3 breast cancer. And so this was in 2013. So obviously now she's, 10 years out. And this is going to vary a lot. Now, she's very specific here about saying that she has a triple negative, meaning progesterone negative, estrogen negative. but it's still going to depend on what your oncologist says and all these different scenarios, whether or not you are a candidate for estrogen or what kind of drug you potentially may want to be on. But this is the scenario where I see this really playing out, which is somebody who is rapidly losing bone, typically on some kind of an aromatase inhibitor, which is or an estrogen blocker in general, but something that is going to just decimate estrogen, which arguably is the same thing that happens when you go through menopause, just it happens more quickly. And the speed matters. And so for people that are on breast cancer therapy of this type, they will see rapid bone loss. And this is a scenario where I would say, well, gosh, it actually might make sense for you to use a drug that blocks bone loss in this circumstance, because yes, I don't like the drugs, and yes, there's negatives and there are side effects potentially, but blocking that rapid bone loss could be really helpful. And it's probably the most powerful drug class for that. There are some other options we could talk about too. But in that scenario, I would still say, don't just lean on the drug. To answer your question, Sarah, yeah, build a comprehensive program so you know that you're getting the right nutrition, you're getting the right supplements, you're hitting all of those things based off of biomarkers that you know you need. And then let's get aggressive about building bone, right? Let's do the resistance training. Let's, you could talk about other anabolic things. You can talk about things like testosterone, progesterone, and peptides. Like, you can build a program around this so that, yeah, you know that this thing is happening, but don't be a victim of that thing. Let's stand up and fight it.
I love that. Love it. Love it. Looking at the next question, can strontium citrate reverse severe osteoporosis? T-score is -4 and -3.
Yeah, and I appreciate her asking that question in a very specific way. So she said strontium citrate, right? And so there's a lot of confusion around this, and I talk a fair amount about it because a lot of people will look at the strontium literature, but almost all of the strontium literature is on strontium ranelate, which is a synthetic drug that was marketed and sold in Europe, which is now taken off the market because it has some concerning side effects, blood clots and some other kind of weird immune things. But that was likely due to the ranelate part, the synthetic component of it. So there is not a lot of literature looking at strontium citrate, although there are a few human studies. But like most supplement and nutrition studies, it is an intervention with multiple things. And so, yes, they did help to improve bone mineral density. I would not say on its own that strontium citrate will reverse osteoporosis, especially if you're starting from a severe endpoint. So I would use this potentially, and we do use this as part of a comprehensive program, but not as a standalone treatment.
I think that's really clear. The next question is about bioidentical hormone treatment. Mm-hmm. Is that helpful with osteoporosis?
Absolutely. Can't stress this enough. If you go back before the early 2000s, when the Women's Health Initiative and other big studies on hormones came out, the primary drug of choice for osteoporosis was estrogen. So there are probably people that are listening that remember, go back to the 1980s and 1990s. And if you had a bone health concern, then people checked your estrogen and you went on estrogen. Or at least this is what I was told. I was quite young. So, yes, it absolutely does help. And estrogen, even today, carries an FDA approval for osteoporosis. So estradiol, to be accurate, carries an FDA approval for osteoporosis. But progesterone does not, and testosterone does not. And I talk about this a lot because when we do hormone replacement, I don't like to use estrogen alone. And for a woman with a uterus, the standard of care is to use a progesterone-like compound. But unfortunately, in the traditional medical model, they're using synthetic products called progestins, which have negative side effects like causing osteoporosis, among other things. And so you have to be careful with what you're getting. And she said very specifically bioidentical hormone treatment. So for me, what that means is estradiol, potentially with or without estriol, depending on the patient, a progesterone, micronized progesterone, which is not a progestin. And then I also really like testosterone for osteoporosis, even though it doesn't have a strong direct impact on bone, has a strongly indirect impact on bone through the evolution of muscle mass and being anabolic, energy, vitality, vigor, all the things that come along with testosterone.
Interesting. Very interesting. Mm-hmm. The next question is a breast cancer question. Mm-hmm. I had a triple negative stage 3 breast cancer in 2013 at age 38. Mm-hmm. 8 rounds of chemo, 25 of radiation, 5 surgeries.
It says including oophorectomy, which is removal of the ovaries.
Okay.
Yeah. And she goes on to talk about having had 3 DEXA scans and watching them get progressively worse. And she's wondering if the chemo or the loss of hormones was responsible for the bone loss. And what should she take to combat it? And so I was actually kind of commenting on this earlier. This is that scenario where the answer is yes, it could have been the chemo, depends on the chemo. Certainly loss of hormones played a role. If you had your ovaries removed, then obviously you went through a surgical menopause at 30, at 38 or whenever they did it. So absolutely, you're going to see an impact to your bone there. And so then the question is are you, for me, if this was my patient, I would have a very kind of difficult conversation around the question of what did your surgeon say or your oncologist say about, are you a candidate for estrogen? You are 38, way too young, in my opinion, to be without estrogen for the rest of your hopefully long life. So, can we do this? What are the risks? She mentions triple negative, but how do they feel about it? And this is a challenging back and forth, because a lot of times the oncologists will say, nope, there's too much risk, even if they're triple negative, which means it didn't actually respond to estrogen. And there's evidence to say that estrogen is protective of breast cancer. So this is a really challenging situation. And it's a tough one, because we have to go kind of back and forth. And it's difficult for the patient. And the oncologist is doing their best because they want to prevent recurrence. But I'm looking at this patient and saying, okay, you're 38. So let's say you're going to live until you're 90 or 100 years old, and you want to have good bone quality and muscle quality and quality of life and a libido and all the things that come along with having sex hormones. What's the risk of not doing something, right? And so, yes, you are potentially at risk of developing a recurrence of breast cancer, but what about not doing anything? And what does that lifestyle look like? What does that health span look like? And it's a really hard one to nail down. So it's a tough one.
Is trying it out to see a viable option and then looking at how things go? Is that?
Well, the problem is that the how things go ends with a diagnosis of a recurrence of breast cancer.
Oh, yes, got it.
Because there's no other endpoint, right? You could say, well, I feel great on hormones, which you will, especially if she's been without them for a couple of years. She knows what going through menopause feels like at 38, and it probably doesn't feel very good for most women. So she's going to feel great on the hormones, but then see how it goes. But what if that is, recurrence of breast cancer? So it's just a tough one. It's something that is a very, very much a case by case scenario.
Thank you. The next question: how do you balance the needs for bone regeneration versus meds that you're required to take for other conditions? Mm-hmm. So in this case, I've been taking 3 meds that create a decrease in bone density. There are some statins. I think this is actually a question that I would love to see answered in a very general way, because I think there are many people in our audience who take different medications that are going to cause bone loss. How do you navigate? What can you do about that in a situation where you have other medical conditions where you have to take medications that cause bone loss?
Yeah, so I was just reading the rest of this. And so she brings up some really good points. And this is why I think a lot of women are so confused, because part of her concern here is absolutely real. So she talks about anastrozole, which is an aromatase inhibitor, which is a drug that blocks estrogen. So yes, again, it's that same conversation that we just had. So what do? You build a program around that, and you decide, of course, do you have to be on it, and talk to your doctors about that. But she also talks about, she described it as L-thyroxine, which would also be called, Synthroid, or all of the other potential names for thyroid medication. But they are all the same thing. They're all T4, a synthetic form of T4, which is a thyroid hormone. And the challenge here is that people say, well, thyroid medication causes bone loss, but it actually doesn't, as long as it's well managed. So if you optimize thyroid hormones through replacement, you're not going to have a negative impact on bones unless you overdrive it. And a lot of people do overdrive it. A lot of doctors will lean on this lever really hard because they're not identifying why they have thyroid dysfunction in the first place. So they just throw thyroid medicine at it, and people feel better, but they don't feel great. And then they start getting jittery and they have osteoporosis. So you have to understand, again, what the numbers are, and that's a big deal. And then she also mentioned statins. Statins are really, it's a funny drug class because there's so much negative press in the lay media and social media about statins, but really there's no evidence that I know of that statins have anything to do with osteoporosis. So it's just interesting. But overall, this is why I think people get so confused and upset that their doctors aren't talking about these things, because it's hard to know which ones of these are real. So we just gave like 3 very good examples of one that's probably not real if managed right, but I don't know what her numbers are, one that's totally not real, and one that's absolutely real and should be managed. And this is why having a custom plan based off of information with somebody that knows what they're talking about is critical, because this person could go down many different pathways and some of them would not have a good outcome. And so this is why this is such a difficult problem for people to manage on their own.
It is. It is a huge thing. I appreciate what you're doing with your medical practice so much. It is so desperately needed. The next question, I think, is one that we've already addressed. It talks about fear of medication. And again, that's going to be a really personal thing.
Mm-hmm.
So this next question is, what are the most common causes of osteoporosis?
Mm-hmm. That's a tough one to answer. So I would say it depends on the age range. So I've had a stream lately of young women with osteoporosis. And this is obviously a very different group than our postmenopausal population. Although some of the things are common trends, you just wouldn't expect to see them. So I would say, the most common cause of osteoporosis is not achieving good bone density in the first place. And I say that because, again, I'm working with these younger patients who they're in their 30s, and they have osteoporosis. So clearly they never achieve good peak bone mass. But I think that's true for everybody, because if you do achieve good peak bone mass, even if you have, let's look at the like hole in the roof scenario, which I'll describe in a second, but like you have a couple of holes and they're leaking and you're losing bone, but if you have a good starting point, it probably doesn't matter for a normal lifespan. But if you have a low starting point, then it really matters. If you have a low starting point and you go through menopause and now you have osteoporosis at 53, it's probably because you didn't have good bone to start with, or at least good bone density. So I think that's the most common thing. The second most common thing is going to be loss of hormones. I mean, whether it be young women, and this is the case for these young women that I'm working with now, but young women who never really had a good cycle in the first place, they went on birth control. I already mentioned that progestins and hormone replacement cause bone loss. That's also what's in birth control pills. So if you're not cycling, you're not getting the normal stimulus of estrogen and progesterone, and you're on a birth control pill, the progestin that causes bone loss, it's a very good likelihood that you're going to have issues with your bones. So they have to have that issue young. They also have eating disorders. They're athletes. They have the whole female athlete triad thing. So that happens there, but then it also obviously happens in the postmenopausal women because they go through menopause, right? So loss of hormones will cause a predictable and rapid loss in bone mineral density and quality. And it's not just estrogen, it's also the progesterone and the testosterone, because they're all wrapped together. So that's a big one. And then when you get to the next most common thing, I would say would likely be, I'll call it gut dysfunction, but this is also wrapped into poor diet. And so this is a huge one. And this is one that we deal with everybody, because there are so many people, and I'll stand on my diet soapbox later, I'm sure. But I see it right there. I got it. So it's 2 questions down. So I'll stand on that soapbox later, but eating a diet that doesn't have adequate protein, eating foods that are either highly processed, inflammatory, or soaking up all your nutrients and not providing those back through supplementation, or not having a gut that can absorb them. That's all kind of wrapped into the same thing. And that's, again, hard. That's hard to do on your own. Lots of misinformation there. And then after that, we start getting into some of the more rare things. So like, what's happening with your parathyroid hormones? What's happening with your vitamin D level? Are you on a PPI for GERD or acid reflux? Do you have a hernia? Do you need to be, have you been exposed to other things that can cause bone loss? And the list just goes on and on and on and on, and it is pages long. And this is, again, one of the challenges of osteoporosis, and why when we approach this the way that we do, the first thing we say is, why you're losing bone. Before we come up with a treatment plan, I want to know why you're losing bone. And we start a lot of people in the same place, because like I said, we see the gut dysfunction and nutrition issues rampant. And this is why we've also created kind of a self-directed program, because so much of this stuff is easy. Like you don't actually need to talk to me to figure this out. You just need to understand, look, this is the framework that helps build bone. Do this and let's see where you are, and then if you still need me, let me know. And so we're in that process now, because again, we've found that there are some very predictable things that we find in this population.
And it's also really helpful to be able to reach more people,
Mm-hmm.
and to make it accessible to more people too. which is
Yeah, I'll just speak to that for a second. So we hit a saturation point in my practice where I'm booked out so far. Like we almost can't. We are taking patients, but we're taking like one a month for me because I'm kind of booked out. But I am opening this up to, I have a PA that's been training with me for 6 months. So, we are looking at different ways that we can continue to spread this information and help people to come up with these custom programs based off of the same training. And so we are opening that up, and that'll open up also different price points, and then self-directed program, which is going to be at a very affordable price point for most people.
I think it's a huge thing. We need more people doing this. We need more medical professionals who are willing to tackle this and take this on. And the effort in your practice to make this information accessible and to create a plan it's huge. It's really huge.
Thank you. I appreciate that.
Looking at the next question, we have.
Is this the trace minerals question?
Yes, the trace minerals question.
Yeah, I can see it easily. I can lead this if you like. So okay. The trace minerals. So I'll kind of read it, and then I'll just combine this with the next one because they're sort of the same thing. But so this first one says, what can cause me to have low trace minerals? B12. So there's a space there. B12 and B9. And then even though I eat a lot of healthy greens, healthy diet, and I'm not taking any medications. She says, I also have sleep problems and was advised by my doctor to increase my trace mineral supplement and add some B vitamins. My doctor said I'm low because of our soil, which is depleted. After 6 months of taking supplements, I am sleeping better. What are some of the reasons why the deficiency could happen, and what effect does it have on my bones? And then, well, I'll just separate this one from the next one. We'll just speak to vitamin levels. So we test the vitamin levels that you can test in blood. We test those in everybody. We do functional testing to look at breakdown products of other vitamins in some people. It just depends on what their starting point is. And what I can tell you is that if you're not supplementing, I don't care what your diet is, you're deficient. And what this doctor was saying is that they're low in this patient because their soil is depleted is absolutely true. Even in regenerative, beautiful farming practices, it's still tough to get some things like copper and magnesium, copper, which you can't measure, by the way. But magnesium we can measure, and it's low in everybody. And it doesn't matter what your diet is. So that's true. So I think we are stuck in a situation where supplementation is going to be required for some core things. As far as diet, this gets into kind of the next question. So maybe let me just read that, and then I'll sort of circle these together. So that next question is, I'm following a keto diet. That's, well, I'll explain that in a minute. And what effect it has on my bones and my diet. I always keep track of my protein intake, low carbs and fat. My protein intake, low carbs and fat. I'll have to clarify that. I recently switched to goat milk, goat yogurt, and goat kefir instead of heavy whipping cream due to dairy issues. Interesting. What is the right amount of carbohydrate and fat for me? How do I get enough nutrients for my food? And I would like some more guidelines from you. Leafy greens in 2 meals, limit starches, and then add fruit. Not clear on how much leafy greens in your book. Oh, she called me out on my book. Just want the best diet for my needs and bone health. So thank you for that. I appreciate you reading my book. The book, though, the nutrition chapter it's short, and it's general intentionally, because here's the issue is that I can't tell this person exactly what to do because I don't know their situation. I will say in general, following a low carbohydrate diet is totally fine for bone health and for building muscle mass. I don't think any issues. Not everybody can take or can handle being in nutritional ketosis all the time. I think some people do really well with it, but some people don't. And so some people have to cycle in and out of it. So that's the question of, how much carbohydrate do I consume? It just depends on what your body can tolerate. Is this a woman? Is she still cycling? Timing that around your cycles, there's so much there. Just a couple of things to talk about in here though. So if anybody is on a keto diet, I think that what this person was saying is that they are keeping track of their protein intake. They are low carb. I hope she's not saying she's also low fat, because that's a very difficult way to do a keto diet. So for a nutritional ketosis, you need a relatively high dietary fat diet. And don't be afraid of dietary fat if that's what you're going to do, because that's what you're eating. And either you're going to tolerate it well or you're not. The protein intake has to be moderate. It can't be high in nutritional ketosis, because protein if your body isn't utilizing the amino acids immediately, they will get converted into carbohydrate, have an insulin response, and not get a ketosis. So you can't be too high. For me, though, where we're putting most people, we start people at 1 gram per pound of desired body weight. And so for most people, that's not going to kick them out of ketosis, but it's close. It's really close. And so we see people that are trying to lose weight and build bone, which is another whole topic, that will likely slow down their weight loss because it puts them in an anabolic state to build bone and build muscle. So you potentially have to decrease it from that perspective. I want to also mention dairy a little bit here. So I see this confusion too. She brought up so many good questions. So she said, I recently switched to goat milk and goat yogurt and goat kefir instead of heavy whipping cream due to dairy issues. So the interesting thing about heavy whipping cream, even if it is coming from a cow, even a conventional A1 producing casein cow, there's not a lot of casein in heavy whipping cream. There is some, so it's possible that you could be intolerant to that, but there's not much protein in it. It's mostly fat. So probably don't need to give up heavy whipping cream unless you're really intolerant to dairy. And then goat is great because it's A2 instead of A1. You can also get that from an A2 producing cow. So those products are out there and available. I'm on kind of a kick right now learning more about raw dairy. I think there's some really interesting information out there on that. I'm not ready to say that that's the thing to do yet. It's also illegal in about half of the country. So maybe I shouldn't say that out loud. But I think it's interesting to know that there are some big differences in well-produced raw dairy versus pasteurized dairy. So maybe more to come. Ask me in a couple of months. But I think this is totally reasonable. And then as far as the questions of like how much leafy greens, how much starches, it just really depends on what you tolerate. So I wish I could be more helpful, but I would need more information.
Fair enough. Moving on from nutrition, there's a great question about what you know about REMS, the REMS.
Yeah. Mm-hmm. So REMS, I was going to almost say what that acronym stands for, but I'm not going to do it because I'll probably get it wrong. But anyway, it's an ultrasound study. So if you're familiar with ultrasound, like you would get at your GYN office, looking at babies and uteruses and ovaries and stuff. An ultrasound can also look at bone. So this is a very specific ultrasound designed by a company that has looked at thousands and thousands of scans. And what they're able to do is give a pretty good estimate of T-score, potentially better than DEXA, but we can't prove that. So I would argue probably better than DEXA. But then also they can look at what's called a fragility score, and that is your bone quality. So I really like this if you have access to it. The downside is that it's not widely available. So I think in the US, I know of 4 machines, and 2 of them are in North Carolina. One of them happens to be in Asheville, which is purely coincidental. I don't own it.
Why not?
Because they cost $50,000, Sarah.
No, I'm hoping that they will trickle down and become more readily available. I'm thinking, did it start in Italy? Do I have that right?
That's correct. Yeah, they're Italian. Pretty sure they're Italian, either Italian or Swedish, but I'm pretty sure they're Italian. I think they are more available in Europe than they are here. The challenge is just you would need to have a pretty high volume of people using it to charge a reasonable amount. Let's call it, that's $100 to $200 for a scan. To think about if you wanted to finance $50,000, how much money you would need. And for most people, they're not seeing that many patients with osteoporosis. So it doesn't make sense from a business perspective. If I had a brick and mortar location and wasn't practicing all by telehealth, I would have one because I do see that many people, but I don't.
Yeah, because you're helping people all over the country and the world.
And world now, I know I was just talking to one of our first international patients today and working through all those hoops. That's fun.
Yes, it is. We appreciate it though. In looking at, there's a question about, let's see. Okay. Here's an interesting one. I'm an active hiker, cross-country skier. She's 66 years old. She has an osteoporosis diagnosis in her spine and osteopenia in her hips. The doctor would like to start her on medication. She's wondering about where to start.
Yeah. So I'll just walk through my framework here, which is But I'll just start to say, like, I don't prescribe drugs very often, but we do, and that's the advantage of working with a physician-led team. I'm not saying me, but like working with a physician who has the ability to prescribe not only osteoporosis drugs, but also potentially hormones. And I do see that relatively frequently. People working with a functional doctor for their osteoporosis, they can't prescribe hormones, and so you only recommend what you have access to, right? And so just keep that in mind. As far as the framework for drugs, though, so our starting point is let's figure out what's your risk of fracture. Now, that's not necessarily an easy question to answer. We can use things like the FRAX tool, which is available online. You can look at T-score, REMS if we have it, and the fragility score. So we try to get a sense of, how fragile are you? If at all possible, we start with a comprehensive program that does not include drugs. But if the starting point is so bad, let's call it like a T-score of, less than -4, and or somebody who has already had a fracture, somebody with a bad T-score, they've had a fracture recently, they're recovering, that person is at imminent risk of a fracture, right? So we can still say, look, I can't guarantee you this, but we could potentially do this without drugs. This is what it would look like. But if we're going to use drugs, let's talk about these things. So then the question is, really, are you losing bone rapidly, or are you having a problem building bone, or both? And so this is why I mentioned earlier, the bisphosphonate drugs, the drugs that slow down bone loss. If you are, let's call it, 15 years out from menopause, let's say you're a 65-year-old woman, and you've went through menopause 15 years ago, your estrogen levels have been stable at essentially 0 for several years, if not a decade. It's not likely that you're rapidly losing bone, right? And we can identify this in bone biomarkers. And so if you were to go on a bisphosphonate at that point, you might not see much benefit. Whereas you might have a bone building problem. So let's take that same person, you get the bone building marker, the bone building biomarker, easy for me to say. You get the bone building biomarker and it's really low, but they're not rapidly losing bone. So then in that case, I would say, yeah, let's use a drug that can actually really drive bone building forward. And that would be a drug like Forteo and Temlo, which is what she mentions here. So it's going to depend for me, on what the biomarkers look like. And that's why I would never make a recommendation for a drug without knowing the answer to that question. Are you losing bone, or are you having a hard time building bone?
So the question of where to start really is, why are you losing bone? What's going on? And checking the biomarkers. And then we need to get Dr. Lucas to say bone building biomarkers 10 times really fast.
Yeah, right. Man, I don't know that I've said it like that before. We'll say biomarkers for bone building. That's way easier.
Yeah, I like it. So in looking at things, there's a question that I think, I know it's one that I get frequently, and it's, does a vibration platform help with osteoporosis?
Yeah. So I'm curious to hear your thoughts on this. The research that I've done, and I have a YouTube video on this that I probably need to update, but the research that I've done on this would demonstrate that there is improvement with whole body vibration. The two companies that really stand out, so Merodyne is one company, and Dr. Rubin, I think, is I don't know if he's an MD or a PhD, but he's one of the developers and leaders on that side. And then the company PowerPlate, which is the same company that owns the equipment called Biodensity, which is the precursor to what is now known as OsteoStrong. PowerPlate and Merodyne both make products that are specific for osteoporosis, although they have different technology. And I think there's evidence for both of them to support the idea that these things will help to increase bone mineral density and likely bone quality, and they should be relatively safe, although there are some risks.
I've seen things that show that it's also a positive thing. The other thing to mention on the exercise front about the vibration plates is that the vibration is going to help to improve balance, which is going to help to reduce the risk of falls and be beneficial that way as well.
Yep.
So that would be the only little PS I would add.
Yeah, well, and so I got a lot of feedback when I did a video on it, and so many people were worried about the fear of retinal detachment, which, it is buried in there in the research that this is a risk, although in the studies that I looked at, there were never any cases of it, but they weren't that big. So I think that risk is real. And if they have, if people have a history of retinal detachment or concerns about the retina, then probably don't get on one. But I don't know that we know what those numbers actually look like. So everything has a risk. So I think that's probably the one there. The other thing that I would say too is really make sure that you're getting the product, and this is more an issue with PowerPlate because Merodyne only has one that I'm aware of, but with PowerPlate, they have products that are not osteoporosis specific, and I don't know enough about the company to know whether or not they all have the potential to have what is called low amplitude, high vibration, or if that's only true in some of the models. So probably just make sure that you know which one you're getting.
What you're getting. I think something that's important to consider there is that just like where we're talking about medical plans being really individual and that our plan has to be personalized for us, and looking at vibration or exercises, that there has to be room to recognize that the same thing is not going to necessarily be right for every person.
Yeah.
That what we're talking about are the general things, but that they're all unless we're specifically looking at this particular person and their needs, that it's hard to say specifically for sure about everything.
Right. And this is again, working with somebody who knows you is really important.
Yes. Yes. So we have the diet soapbox that we can open up. What's the best diet to follow? We've touched on that one briefly. Do you want to soapbox this one today?
Sure, I'd love to. Yeah, and so my perspective on diet, I'm actually recording a video later on part of this topic, which just keeps coming back to haunt me. And so my perspective is that if you want to build bone and you want to build muscle, you need to follow some of the principles that have been very well established in, the bodybuilding community for decades and generations, right? So if you think about a bodybuilder, and I'm not suggesting anybody who's watching this needs to be a bodybuilder, but if you think about the people that have figured out how to build stuff, it's those people, right? Like those guys know how to build stuff. So if you think about what they do, and I'm not saying either that you should go to the extremes that they do, but the principles are sound. And that is, if you want to build muscle, you need adequate building blocks, just period, right? And so for me, that is a protein forward diet. And I'm not saying a high protein diet, but a protein forward diet. For most people, that is 1 gram per pound of ideal body weight. Most people in this population actually are close to their ideal body weight, which is different than most populations. And so probably pretty close to 1 gram per pound. Now, the only caveat to that is if you have chronic kidney disease, your kidney's ability to process the protein is impaired. So check with your own team. If you're on a protein restriction, then you need to either inquire about that or follow that. But other than that, protein is not hard on the kidneys. We hear this all the time. It's rough on your kidneys. It's going to cause kidney failure. Not true at all. The upper limit of safety is more like 3 grams per pound of body weight. So, for me, I'm just under 200 pounds. So I couldn't fathom eating 600 grams of protein in a day, right? Like we are nowhere near that much protein unless you are really trying hard. So we don't need to worry about a safety perspective, but if you want to build bone and muscle, that is the most important thing. And that's what we start with most of our patients. If you don't want to track food, fine, just track your protein. That's the most important thing. All right. So then the next most important thing is making sure that you're getting all the nutrients that you need. And so then this is where we get into this. Well, actually, it's probably not the next most important thing. So let me finish that statement and then I'll put one in the middle. So the next most important thing is getting adequate nutrients. So this is, for me, a Mediterranean style diet. So the reason why I say that is that in a Mediterranean style diet, it's going to be lower inflammatory. You're going to get leafy greens. You're going to get all of the things that probably going to provide as many nutrients as you can get through diet. Fiber, if you tolerate fiber well, like it is probably the best, if you're going to name a diet, probably the best diet. And it's been shown that for everything under the sun, right? The problem with the Mediterranean diet is it's relatively vaguely described, which is also probably the reason why it's good for everything under the sun, because you can change it to make it whatever you want. Like it can be keto, it could be almost completely plant-based, it could almost be carnivore, right? Like you can change it in a lot of ways. And so I use that term because I like the principles of it, but how you actually make that work for you is going to be very unique. The one thing I wanted to mention that's in between those two is this, and this is the video that I'm doing today. This will be my third video on this topic on my YouTube channel, which is the pH alkalinity question. Yes. So you see a lot of people, a lot of influencers, and I'm calling one out today that I won't mention right now. But you see a lot of influencers who will talk about measuring urine pH and make sure that you alkalize your diet. And in order to do that, you need to eliminate or restrict severely animal products. Clearly, if you're going to do that, you are going to fly in the face of what I just said is the most important thing, right? You cannot do both. So I'm going to demonstrate today in my video evidence to suggest that anytime somebody says, here's the evidence that supports doing this, if you look at that evidence, it's garbage. So this is what I'm going to do today in this video, and I'm really ramped up about it because I'm really passionate about this topic. But I'll just summarize it to say that this influencer who says that she's a 35-year vegan and that you need to eat this way, and this is the evidence that supports it, that evidence is garbage. It's all based off of growing cells in a petri dish and what happens when you change the acidity of the surrounding environment. We are not cells in a petri dish, and we are not mice. And you can actually do the same thing in mice, but again, we're not mice in a cage either. And you see this in the longevity literature, same thing. If you restrict calories and protein, you'll live longer if you're a mouse. True. Do that constantly in a human and you will fall and you will break your hip and you will die, because we live in a world where we have to step over curbs. We have to get up off the ground, right? Like, we're not mice, we're not this tall. And so I strongly fight back against this, because I think for most people, they end up limiting or restricting severely their protein intake, which is going to severely inhibit their ability to build muscle mass and to build bone. So I strongly recommend not measuring your urine pH. You are only measuring your body's buffering capacity, and your body has a tremendous ability to buffer anything that is quote unquote acid forming. If you want to eat a quote unquote alkaline diet, fine, eliminate all of the other acidic things that exist, or the acid forming things that exist. So that's added sugar, processed food, alcohol, chocolate, grains, right? Like, I don't hear anybody talking about the pH thing that says don't eat bread, chocolate, and wine. Why not? Right? They only use it as a way to push into eating a vegan and vegetarian style of eating, which is not what the literature says. And so I find it's really frustrating, because if you want to not eat grains, not eat bread, not drink wine or any alcohol, and not eat added sugar, knock yourself out. You will absolutely be better for it, but not because of its effect on your pH.
Yes. It's because we're eating a whole foods-based diet with real foods that are coming as close to the source as they can. There's something that I think this is, just Sarah's opinion out here, but I think that our bodies are intended to eat according to our teeth. We're supposed to eat a variety of foods, and those should be whole-based foods. In some ways, you look at animals and they've got this one right. Animals that have sharp teeth eat meat. Animals that are supposed to eat a plant-based diet do. They eat according to their teeth. And I think that it would serve us well if we got on board.
That's right. You don't see cows looking to eat meat, right? Yeah. It's interesting. One caveat, or it's not a caveat, but one interesting, this would be kind of both ways. So I guess if you look at gorillas, because I hear this a lot, right? So you look at like big monkeys, gorillas. I'm not a zoologist. I don't know the difference here, but the big ones, right? If you look at big gorillas, apes, they do have fangs, so they're capable of eating meat, but they mostly thrive off of eating plants. And one of the vegan and vegetarian sounding points is how do dinosaurs get so big if plants aren't healthy, and how do gorillas get so big if all they eat are plants? But the difference is their gut versus our gut, right? So a gorilla has a big, redundant, large bowel that can ferment plants and create fatty acids out of it, right? So they actually will create all of the amino acids, some of the amino acids, but fatty acids that then can feed their body. But we don't have that, right? Our GI system is not designed to ferment, and you don't want it to. That's called SIBO. Our GI system is not designed to ferment plants. So we need things that will be absorbed efficiently and quickly, and that's mostly meat. And this is, if you listen to the carnivore community, this is their argument, to say that our GI system is designed to eat meat, and they would argue exclusively. I don't think that that's probably true for everybody. I think there are some people that will thrive in that environment, and I have plenty of patients that are eating a carnivore diet and they are doing great, and their gut microbiome looks great, their biomarkers look great. But then we also have people that eat a completely plant-based diet, right? And if formulated correctly, they're not necessarily doing harm. The challenge is I see people that come in eating a plant-based or vegan diet, and they're struggling to do it well, and they're limiting too much protein. They're not getting adequate protein. They're falling into the vegan commercialism trap, which is eating a highly processed food diet, right? Those people are not doing well on a vegan diet.
Yeah.
So I don't think it's fair to say that there is one diet that fits everyone. We have to figure out what is right for us.
Bio-individuality.
Right.
That's a beautiful thing. All right. We're moving into some of the exercise questions. So
Great. So I'm going to learn something.
Something that I noticed is that there were quite a few questions about scoliosis and osteoporosis together.
Yeah.
And I wanted to speak to that. And I'd like to talk about some general principles at work here with scoliosis and osteoporosis. So something to keep in mind is that osteoporosis can actually cause degenerative scoliosis. And when that happens, it can be very painful and it can put a lot of pressure on our internal organs. So there were, some of these questions are somewhat related. In looking at scoliosis, when you have the curve, the inside part of the curve, the muscles tend to be really tight, and the muscles on the outside part of the curve tend to be stretched out and loose. So with osteoporosis, we're of course trying to build strength. Dr. Lucas talked about a little bit earlier about how we have to have the right nutritional building blocks in order to build bone. Once we have the right things in our body and we have those essential building blocks, then we can use our bodies to put good stress on our bones and to build strength and to improve bone quality. So when you're looking at scoliosis with osteoporosis and you have this tight side and then this weak stretched out side, it becomes a little bit more complicated to try and work on the strength building. There's a general principle with scoliosis, any type of scoliosis, and that's that the first thing that we want to do is to try to get these muscles in here that are tight to relax. What we really want to do is to create balance between this tight side and the weak side. But in order to do that, the first thing that we need to do is to relax the muscles on that part of the curve. This is often accomplished by starting with a restorative pose, something like laying out a bolster. You could use a sofa cushion. If you don't get down onto the floor, you could even use several long bed pillows. Put your bottom in front of the pillow apparatus, whatever that happens to be, and then lay back so that your back is on this series of pillows, and give yourself the opportunity just to breathe. You want to open up through the thoracic section, through the middle portion of your back, and you want to let this section in your body relax. There's so much pain in this area that we want to be able to breathe comfortably and freely first. And then once that area of the body is relaxed, then there are several things that we can do to try and work on strength. Before we get into the strength part, it's also important to consider the hips, because the hips are attached to our spine and we're working our way up the chain. And so often people that have scoliosis, they also have pain in their hips. There can be a misalignment in the hips. And I'm assuming that I'm not actually teaching you anything here, Dr. Lucas, that you actually know all of these things. So this section where we're working with, we want to work through the hips. You could do that by gently bringing one knee in at a time. And looking at osteoporosis for exercise, it's essential that we don't come into a shape that rounds the spine, a C shape. So I'm just going to demonstrate what that looks like here. So coming into this rounded shape, we don't want to come into this rounded shape. There are so many exercises where we lean forward, we reach to touch our toes, we're bending forward. You think about a lot of abdominal work and we're doing crunches or sit-ups. None of those things are safe to do with osteoporosis. And so when you're looking at building strength and getting into the hips both, these are best done, I think, laying down on your back with your back flat. So when I'm talking about working through the hips, to be able to ease pain with scoliosis, you want to bring one leg in at a time and leave the other leg out. By leaving the other leg out, then you ensure that your back is going to stay straight, that it's going to stay flat rather than coming into any kind of a curved shape. You could gently work on bringing your knee in little circles going both directions. That would help to gently work through the hips. That's going to help to ease some of the tension and pain that can then come into the spine because of scoliosis. Let's see. I'm looking at the notes that I made so that I don't forget things. Okay. Strength is the next topic here. So after we've relaxed this area, we've worked through the hips, then it's really important to build strength. We want to improve our postural muscles, and that's going to be helpful for both scoliosis and osteoporosis. Something that's really interesting, it's a very simple move. It may be accessible and it may not, but just creating extension where we reach our arms up overhead. This simple movement of creating extension through the spine, it helps to improve postural imbalances. So unless you've gone to see a physical therapist or a doctor and had specifically diagnosed exactly what's going on, you may not know exactly what the postural imbalances are. So for me as a yoga teacher, something that helps to improve postural imbalances in people in a very general way is to create extension in the spine. That simple movement is really helpful. So we want to work on doing things that are going to build strength. And coming back to my simple movement with extension, when you reach your arms up overhead, one of the things that you'll notice that happens is that your abdominal muscles start working just with the simple movement of reaching your arms up over your head. We want to have strong tummy muscles because they're going to provide strength to help our postural muscles. There is a way in yoga to work on improving scoliosis. You would want to work in person, I think, with someone or in a one-on-one capacity with someone online. And you want to work with either a physical therapist or a fitness professional that has been trained to work with someone who has scoliosis and also that knows how to do osteoporosis safe exercise with both things. Because if you're going to work in an asymmetrical way in yoga, generally in yoga, we work symmetrically. We work on one side and then we work on the other side and we go back and forth. But if you have scoliosis, you can work on improving the scoliosis, working in an asymmetrical way, but you absolutely want to double check and know which side your curve is going so that you don't get things going the wrong way and aggravate and make things worse. Let's talk about something that can be, that people should avoid with scoliosis. And this is going to bring me into another question that came up, and that was twists. So in looking at scoliosis and osteoporosis, twists can aggravate scoliosis. So twists would definitely be something that you would want to avoid if you happen to have scoliosis and osteoporosis. The twists are a whole other can of worms to open in general with osteoporosis. I'll come back to the twists in a moment, but I just wanted to touch on looking at scoliosis and osteoporosis together. Principle-wise, you want to work on relaxing that area to review, and then you want to work through the hips, and then you want to work on strengthening that area. Some poses that you might do that would strengthen your spine would be small back bends, extension, and bridge pose, lying down on your back. My husband, who's tech support, is pointing at trying to keep me on track. I can get going on exercise and talk for a very long time. So in looking at, let's move on to twists, because I think I'm talking and I could talk for a long time. Twists are a controversial subject in the realm of osteoporosis. The National Osteoporosis Foundation cautions strongly against doing twists. And if you have a question about doing something, this is something that I mentioned earlier, and it's a really important thing. If you're ever concerned about doing a movement, avoid it. Don't do it. There are other ways to strengthen the spine. There are two bodies of research that would support twists for osteoporosis. There's a group of Italian researchers. There's the Cristofilini studies. And the Cristofilini studies, they took cadavers, they modeled osteoporosis by putting sensors into the spine, and then they moved the spine in different directions and applied pressure different ways. They found that twists applied stress to bones, but it was not as significant, as strong as forward flexion. So if my hands are our vertebrae and we're looking at that forward flexion, that rounding movement, then we are creating a lot of stress coming on one side. When we come in and we twist, what's actually happening, that rotation, we're putting the stress evenly throughout the vertebrae. So if there is not a reason why you shouldn't do a twist, then twisting could be something that could be very helpful with osteoporosis. Dr. Fishman is the other body of research in this area. He's been researching yoga and osteoporosis since 2005. He still has ongoing research in this area. I actually did my yoga and osteoporosis training with him. And he has twists he has 3 different sets of 12 poses that he's been studying for osteoporosis. The published research is the first set of 12 poses that's out and available. And in looking at twists, he would say that at this point, he has over 100,000 clinical hours of people doing yoga for osteoporosis, and each one of them include twists. He believes firmly that twists are a good movement for the spine, but there are reasons why someone should not twist, scoliosis being one of them. If someone has had surgery or there's another condition with their back. So if you are in doubt, the answer is don't do it. If you're comfortable with that, if you don't have another contraindicated situation, then twisting could be a safe movement. Do you have anything you want to add there? Do you want to disagree with me?
No, I have very little to say on that topic. Other than that's why we work with people that are specialists in the space, because it's, for me to go down that rabbit hole, I just don't have the bandwidth. So I'm happy that you said that. I do want to mention, I do have a hard stop in a minute and a half.
Yeah.
I have back-to-back recordings. So I just I was looking through the questions, and one common theme that came up was the topic of OsteoStrong. And so there's probably a lot of people that are questioning whether or not they should or shouldn't participate in that. And I'm actually doing a class for OsteoStrong next week after. And so they actually shared with me some new studies. And one of the critiques on OsteoStrong has been that there just aren't enough big studies. And I know what they say. And the answer is that the risk benefit is for anything like we've talked about, and there's not a lot of risk. There is some, but that the benefit is so potentially strong. Newer studies coming out are showing a good amount of improvement with OsteoStrong alone as an intervention. Bigger studies, 170 people was the study that I just reviewed. So this will be published this year. So I think it is, if you have access to it, I think it's an asset. It is not likely to be good as a standalone intervention, but it is definitely something to consider from my perspective.
I think that's a really good point. They're using scientific principles. There's so much research out there about how exercise can be used to help osteoporosis. And when you're applying those principles and creating a program, even if it's just them doing their own research at this point, I think there's benefit.
Yeah.
Dr. Lucas, I am going to stay on and continue answering some of these exercise questions, but I know you have a hard stop, and I want to thank you so much for your time today and coming to answer questions. You have so much value to add to this audience and this group of people, and thank you so much for your time.
Yeah, thank you. Look forward to doing it again soon. Appreciate it.
Absolutely.
All right, bye.
All right, I'm going to continue answering some of these questions. I have a question about the Superman or locust pose. So there are 2 YouTube videos that are out about the Superman. There's a video by Bob and Brad, and there's also a video by Margaret Martin. They're all physical therapists. And in talking about, is the Superman a safe pose to do or not do with osteoporosis? Where does this fall in? So here's what I would have to say about it. The research that Bob and Brad and Margaret Martin are looking at is a research study that was done in the 50s. There is more current modern research about that particular pose. If you are concerned about it, the advice that I would give, that I just gave about twisting, and that I would give again about the Superman pose, is that if you're in doubt, then you don't do it. Margaret Martin in her video shows a very simple adaptation, and I think she's spot on there. If you're concerned about it, she's not saying not to do the pose exactly. She's saying don't do it in the way that people usually do it. She's suggesting that you can do half of that pose at once. I'll actually demonstrate what she means here. I'm going to bump my camera down, and let me show what she means here with this particular pose. And actually, we can show how to get down to the ground safely with osteoporosis while we're at it. So I'm going to come through the hip hinge, bending both knees, sticking my behind out, and then coming down with one leg and then the other leg, and then making my way down to the floor. So if you're going to come into half of this pose and you bring your arms out alongside your torso, and you'd inhale and you lift your head, shoulders, and arms, coming into a half locust. So this is not putting the same amount of pressure as lifting both sides at the same time. So this would be a way to adapt the Superman pose in a way that even Bob and Brad and Margaret Martin would consider safe and appropriate. Doing the other half, then you bring your forehead down to the floor, and then you lift your legs. So if you're concerned about there being too much compression, too much stress on the spine by doing both at the same time, lifting head, shoulders, arms, and your legs, if you're concerned that this is too much, then you can do it by lifting half and then the other half. So that's a wonderful way to adapt that particular pose. Other small back bends are really important and useful for osteoporosis. This would include baby cobra, sphinx pose, coming in to do a variety of small back bends. All of those are really helpful. They're important for strengthening the back of the spine. There's a study that I actually want to talk about that talks about the importance of doing exercise to strengthen the spine. And there are some really significant things to point out about that study. So there was a study done. It's Elizabeth. Oh, where is it? It's Hoot. Okay. I'm not seeing it on here. There's a study that was done. Oh, it is. There it is. Elizabeth Huntoon. If I just slow down and read my own writing, we're in better shape, right? Okay. So there's a study done by Elizabeth Huntoon and a group of researchers. It was done by the Mayo Clinic, and it shows the importance of doing exercises to strengthen the extensor muscles of the spine. The extensor muscles of the spine are the two thin little muscles that run right along your spine, from your neck all the way down to your spine. They're two thin, long muscles. And strengthening those particular muscles is essential after you've had a fracture for preventing another fracture from happening. So if someone has had a fracture, a compression fracture in their spine, and they don't choose to do exercises, then their average refracture rate is about 4.5 to 5 months, statistically speaking, that they'll have another fracture about 5 months later. If someone has vertebroplasty, which is cement that's put into the spine, I was really hoping Dr. Lucas would still be here to talk about that part, but it's important to be respectful of his time. So if cement were put into the spine and someone does the exercises, it pushes the refracture rate out to about 2.5 years. And if someone does just exercises to strengthen the extensor muscles of the spine without having surgery, then it actually pushes that refracture rate out to about 5 years. So this is a really important thing to understand. There are some interesting things about this study. Strengthening the extensor muscles of the spine reduced the risk of having another fracture, but it didn't actually change bone mineral density. So there are several things that we work on the exercise front that are designed to reduce the risk of fracture that don't actually change bone mineral density. Balance would be, I think, a good example. in many ways there. Balance is essential for reducing the risk of having a fracture. In looking at balance, can you walk forward? Can you walk back? Can you heel toe? Walk. Let me show what I mean here. So in looking at balance, my feet show up. Yes. Okay. Perfect. So when we walk forward, a way to practice balance, can you walk heel toe, heel toe, heel toe? Another thing to practice working on is, can you walk backwards? Those are things that many of us haven't practiced since we were in elementary school. But by practicing those things, we actually improve our ability to walk forward and to be steady so that we can shift from side to side and move back and forth. And improving balance really helps to reduce the risk of fracture, even if being able to walk heel toe isn't necessarily going to improve your bone density. It helps to reduce your risk of a fracture. And reducing the risk of fracture is something that we're all really focused on. That's critically important. I'm going through and looking at other questions to see if there are other things here. What are the most important exercises that could prevent bone loss as we age? There's a lot of data on the internet, so be specific. All right, I'm going to be specific as I answer this one. Weight-bearing exercise is the most important kind of exercise that you can do to prevent bone loss as you age. So weight-bearing exercise can look like several things. You could go to the gym and you could lift weights, or you could use your own body weight. On using your own body weight, that could look like either yoga or Pilates. I teach yoga for osteoporosis, and I don't remember her name, but I know that there's a woman that had osteoporosis young. She was a professional dancer. Her program is Buff Bones, if anyone's interested in doing Pilates that way. So I'm your girl if you want to do yoga for osteoporosis, and she's your girl if you want to do Pilates for osteoporosis. So there are lots of different options. You could also go to the gym and use weights. You want to work with a trainer who knows about osteoporosis to make sure that you're doing things in an osteoporosis safe way. So in looking at what's important to do as we age to maintain bones, weight-bearing exercise, improving balance, and maintaining the ability to move through the hip. So coming back to hips and having that mobility, it's important to be able to have that mobility through the hips because it enables us to spare the spine. Let me show what I mean about that. So if I were to just bend over and to reach forward and touch my toes or pick something up off the ground, I could come in and my spine is rounded, which is what we don't want. But if I can fold from the hip, so I'm going to bend to my knees then, my knees are about a little bit wider than hip width apart. And then if I can fold from the hip, then I can pick something up off the ground and my back stays straight. It doesn't come into that rounded shape. So having the ability, some amount of flexibility to maintain the ability to move through the hip helps to facilitate safe movement. So that's a really important thing to be aware of also as we age. So things to focus on: weight-bearing exercise. That could be planking on your forearms, planking on your hands, planking, side planking, again, forearms or hands. And if you can't get down to the floor and you're not comfortable planking that way, you can also plank against your kitchen counter or against a wall. Let me show what that would look like on a wall. So I've got my wall over here. Yes, this works. Okay, so my hands are about shoulder height. They're in front of me. My hands are actually just a little bit lower. My fingers are about shoulder height. And then you can lean into the wall and you'll notice that your arms and your tummy and your whole body is working. If you wanted to make this even a little bit stronger, then you could bend to both elbows and let yourself come down further into the wall. So that would be how you could plank at the wall. And it's going to be a strong, good exercise, whether you're on the wall or on the floor or wherever you happen to be. Looking at other questions. Okay, so we talked about twists. There's the Cristofellini research and Dr. Fisherman's research. I also have a YouTube video about this. If you were to look up looking at twists for looking at, do I do twist? Do I not do twist? I have a video called R is for rotation. It's in the ABCs for osteoporosis. There's another one here, looking at kyphoplasty and does spinal cord stimulation help to strengthen the muscles along the spine? Can this help to prevent further fractures? So this is the research study that I was bringing up before, and I made myself some nice notes so that I could answer this, and then I couldn't find them later. That would be me. So research done by Elizabeth Huntoon and other researchers showed the importance of incorporating exercise to strengthen the extensor muscles of the spine. So absolutely doing exercise post-fracture is really important. Something that's important to keep in mind is that not all exercises are suitable for every person. So just like we were talking about how diet needs to be individual to a particular person, and everybody's body is going to need something a little bit different, exercise is going to work the same way. There are general guidelines. It's important to strengthen the extensor muscles of the spine, but there are a lot of different ways to do that. So if you don't feel comfortable doing twists, then don't do them. If you're not comfortable doing a Superman pose, don't do it. Locust or the Superman pose is one of the poses that's part of Dr. Fishman's 12 poses for osteoporosis. So the research that I was saying, the research that Bob and Brad and Margaret Martin are citing was done in the 50s, and there is more current modern research about that. Dr. Fishman includes locust pose because back bends are really important for strengthening the muscles in the spine. So the muscles, the basic process here is that our muscles pull on our bones and we build what we use. So our bodies are going to lay down new bone. We're going to stimulate new bone growth when our muscles are pulling on our bones. That's how this process works. You have to have the nutritional building blocks in, and once you have the nutritional building blocks in, then we use our bodies to stimulate new bone growth. We do that by using them in strategic ways. If you want the muscles in your back and along your spine to be stronger, then we need to do exercises that are going to strengthen our backs. So that could look like small back bends. It could look like bridge pose. It's going to look like planking and side planking. And looking at how to get at the hips are a somewhat difficult area to get at to strengthen. But if we're going to strengthen the hips, coming in and doing balance exercises, tree pose, standing on one leg, coming in and doing a side plank where the weight is loaded into the hips because the hips are stacked. Those would be good ways to specifically strengthen the hips that way. I'm hoping that I'm answering good questions. Please leave me comments. Let me know if there are other things that you're wanting to know about exercise. There's a great question about salt and bone health. There are some interesting research studies out about salt and bone health specifically. Generally, we've been encouraged to reduce salt long-term, and the research about salt and osteoporosis is kind of interesting. It would indicate that salt does not cause osteoporosis, but salt can lead to other problems. So it's important to eat salt in an appropriate and limited quantity. Sugar is really the big bad because sugar can cause inflammation, and inflammation is going to cause all the different kinds of health problems that we have in our body, whether that's diabetes or having osteoporosis, anything. Inflammation, back to inflammation and gut health. So inflammation and gut health are going to be the causes of chronic diseases, including osteoporosis. So limiting the sugar that we consume is actually an important thing. I'm looking at the questions here. There's a question about rebounders. Are rebounders good for osteoporosis? This is a complicated question. Jumping has been shown to be helpful for stimulating new bone growth because of the impact, but I would caveat it because when you jump, once you have osteoporosis, then you could actually cause fracture from the impact there. So running builds bone, And it's really important. I mean, running is a great way to build bone prior to having osteoporosis. If you have osteopenia, please still run, jog. And if you've always been a runner or a jogger, please know that you could just continue to be a runner or a jogger. But if you are, if you're someone who is new to running and you have osteoporosis and you're like, hey, I heard that running builds bone, the impact of running could actually cause you to have a fracture. So it's something that would best be done prior to actually having osteoporosis. You would want to not take up running if you have osteoporosis and you haven't been a runner all your life. So in looking at the rebounder and jumping, the jump could actually cause a fracture. Jumping, you could also actually fall off of the rebounder or have a fall. I know that some rebounders have a handle where you're holding on and a lot of people feel steady and stable. Yes, jumping can build bone. It's probably not something that I would choose to do. I would discourage using the rebounder for bone building. Forms of exercise that don't build bone, cycling, swimming, they just don't have enough impact. They don't pull on the bones enough to stimulate new bone growth. So you want to do something that's going to have weight bearing, whether that's Pilates or yoga or going to the gym. You need to do something that's going to stimulate new bone growth. You need to actually be building muscle and to have your muscles pulling on your bones to actually lay down new bone. But important things to keep in mind to remember are, okay, sorry, my husband's pointing at me. Hey, you've got a new question. I promised to get to that, but I want to finish saying what I'm saying here. So you want to stimulate new bone growth, but in addition to stimulating new bone growth, you also want to do exercises and things that are going to reduce your risk of having a fracture. Balance is really important there. And so is stimulating the extensor muscles in the spine. Should the difference between plant and animal protein be a concern? Can the total protein per day be comprised of both? Shelley, that's a great question. And absolutely, the protein can be combined from both plant and animal sources. It does not all have to be from one particular source. The important thing to consider when you're looking at plant versus animal proteins is that you're getting all of the essential amino acids. So you want to find sources that are going to be complete proteins. Rice and beans are a classic pairing. There are some other plant sources that have all of the essential amino acids in them. Hemp and quinoa and chia seeds all have all of the essential amino acids. But you can combine one plant-based protein with something else and also get all of the essential amino acids. Rice and beans together are that classic pairing where then you have all of the essential amino acids. So absolutely, you can combine between plant and animal sources. What poses should not be done in Surya Namaskar? That's a great question. So Surya Namaskar, we're looking at sun salutations. So let me give a little demonstration here in my jeans with the sun salutations of what to do. And actually, I'm just going to show how to adapt a sun salutation safely. So if you're going to come in and do a sun salutation, reach your arms up overhead, but then instead of coming into a deep forward fold, come to a flat back and stay here. And then from here, instead of just stepping back to a plank, bend your knees, place your hands on the floor and step your feet back into a high plank. Then from here, from your plank, planking is great for osteoporosis. You can go ahead and lower down either all the way to the floor or just up above, coming into either cobra or to upward facing dog. It's okay to come into downward facing dog, provided you keep your back straight. That may mean that your knees are bent and that your heels are lifted off the floor, but it's essential to keep your back straight. And then from here with your knees bent, then you can step forward. I'd probably step 1 foot and then lift up. And then you're going to come into a flat back. And then instead of coming back down to the forward fold, you stay at a flat back. And then you reach your arms back up to the sky. And then you can bring your hands into heart center. So that's how I would adapt a sun salutation. it's important, whatever you're doing, to make sure that what you're doing causes your back to stay straight. There's a lot of research. There are many scientific studies that show that that forward folding motion causes fracture. So it's important to avoid that particular movement. If you've come into a yoga class, you want to avoid reaching forward to touch your toes, standing or seated forward folds. And let me show how to adapt child's pose. So child's pose is a really popular pose in yoga, coming down to the floor. We don't want to come in and do child's pose with our knees together. But if you take your knees out to the sides, then you've made room for your hips. And then you can come forward with your knees out to the sides and take your arms forward. So it's essential to adapt child's pose that way so that you bring it into a wide leg child's pose. You can still do child's pose and enjoy child's pose, but it needs to be done with knees out to the sides. Did I answer all the questions? It looks like you are back bending for flat back. It might with me because I've got a lot of mobility in my back. It looks like you are back bending. Okay, it might with me. I might exaggerate it a little bit. So you don't have to back bend with a flat back. You can keep your back straight. I'm sorry, I don't have exercise clothes on today. Looking at flat back. So for me, probably because I'm looking at the camera and talking, and there's a little bit of the back bending there, you can keep your back straight. Your back can be straight. You could come, wherever you happen to come. This might be, a person might, does that work? Your back, as long as your back is straight, it doesn't have to be, you don't have to come into a little bit of a back bend. It's me looking at the camera and talking, and there's a little bit of a back bend there. You're absolutely right, but there doesn't have to be. You can keep your back flat, just so long as it's not coming into the C shape. Yes, all right. Did we get all the questions? I'm thinking. Have I missed any? This has been an absolute pleasure to do, and I'm really pleased to be able to do this. I think Dr. Lucas and I are planning to do a Q&A like this quarterly. Please let me know if there are other things that you're interested in doing here with Facebook Live. I think we've gotten the majority of the questions. I think we combined some of them together. This has been an absolute pleasure to do with you, and I hope that we will get to do one of these again soon. Thanks. Bye.